Hello, everybody. This is Miss Benita again, giving you just an overview, again, a review of glucose regulation. Again, a review, the endocrine system in general. Remember that we have a pituitary gland in our brain, and it's right in the middle of our brain. And some of the hormones or primary hormones that it releases in regards to med-surg and not maternity are the ACTH, adrenal stimulating hormone, TSH, thyroid stimulating hormone from the anterior lobe of the pituitary, and then the posterior lobe releases ADH, or antidiuretic hormone, or what I call the anti-P hormone. Some of the other endocrine organs, the pancreas is both an endocrine exocrine organ. The endocrine side of the pancreas releases glucagon and insulin, which we're going to be primarily focusing on in this review. Also, on the top of the kidneys, the adrenal glands release mineral corticoids that can help us control our salt level, and that corticoid is aldosterone. Glucocorticoids or help us to control our sugar and stress, actually, and that is our cortisol. And androgens are some of the sex hormones that the adrenal glands get involved with releasing. So that was just kind of an overall view of the whole endocrine system, and we're going to kind of zero in now on glucose regulation. Obviously, you probably know glucose regulation is the process of maintaining optimal blood glucose levels. The primary purpose of glucose regulation is cellular use of glucose for energy, or ATP synthesis. In other words, we need glucose. Every single cell in our body must have glucose to perform its function. And we have, again, our endocrine side of our pancreas releases hormones that help us to control these glucose levels. The one main hormone that we all know is insulin. It helps us to decrease our serum glucose levels, and it actually works like a key and helps glucose to cross over the cellular membrane into all the cells to get this energy. Excuse me. The pancreas also releases what's called counter-regulatory hormones, or hormones that that increase the amount of glucose in our bloodstream, and that hormone is called glucagon. So again, insulin decreases the amount of glucose in our blood. Glucagon, I'm sorry, did I say that correctly? Insulin decreases the amount of glucose in our blood. Glucagon increases the amount of glucose in our blood. There are some other hormones that also increase the amount of glucose in our bloodstream, that being epinephrine, growth hormones, and cortisol, or stress hormone from the adrenal glands. All right. Causes of alterations in glucose regulation: diabetes mellitus, or hypoglycemia. The causes of these things, they have shown to be most of type 1 to be autoimmune and genetic. Type 2, there are a lot of environmental factors involved with that type of diabetes, including obesity, age, and the metabolic syndrome, which can greatly contribute to insulin resistance. And I'm not going to go into detail with all of that with you right now in a short review, but please refer back and make sure you remember what all that was about. This next slide shows you all the different types of glucose lab values or diagnostic studies, and this is a good slide. These you need to know. Hemoglobin A1C, also called glycosated, I don't think I have that spelled correctly, hemoglobin, and it's the average of what our sugar level has been over the last 3 months. If you are equal to or greater than 6.5% or higher, it correlates with the diagnosis of diabetes. Your fasting blood glucose. If you've been fasting for 8 hours, your blood glucose level should be at or greater than 126. Your 2-hour plasma glucose, it should be at or greater than 200. This is also called an oral glucose tolerance test. And those patients would come in and they drink this glucose solution that has 75 grams after they've fasted for 8 to 12 hours. And then they measure their blood, and it should be, again, around 200. When patients are getting these oral glucose tolerance tests, if that level is not normal, that whole procedure of drinking the glucose and drawing the blood may go on for 2 or 3 times. So you need to kind of tell the patient that you could be here for several hours. I know this is a very popular test to do during pregnancy. I believe it's around the 26 week or so point that they do this on all pregnant women. Besides fasting for the 8 hours, like the day before, you just follow a normal diet. There doesn't have to be any restrictions with that. During the test, in between drinking and waiting and the blood draws, the patient can walk around, go to the bathroom or the gift shop or anything. The activity is not really restricted in any way. I won't say you want to go work out, but it's not restricted. You can get up and walk around. And there are several questions concerning that particular test on your unit 2 exam, the oral glucose tolerance test. So you might want to look it up and just be familiar with everything that involves. Random blood glucoses, which is what we do in the hospital a lot of times, those normals at or greater than 200. All right. Signs and symptoms of hyperglycemia, the 3 Ps: polydipsia, polyphagia, polyuria, increased thirst, increased hunger, increased urination. Also, weakness, fatigue, blurred vision, headache, glycosuria, glucose in your urine, nausea, vomiting, abdominal cramps, mood swings. These are all would be chosen in a select all that apply question for someone with diabetes type 1 or type 2, or anytime somebody has a high blood glucose level. The differences between type 1 and type 2, just to refresh your memory, with type 1, there is beta cells are destroyed and there is no insulin released. So these patients have to be maintained on some kind of insulin, and it has to be injectable. Again, those 3 Ps, weakness and fatigue, are all very common symptoms of type 1 insulin-dependent diabetes mellitus versus type 2, or what they now call non-insulin-dependent diabetes mellitus. They don't have adequate insulin. Perhaps there's a problem with secretion or production or resistance. They can experience the 3 Ps and fatigue, and in addition, they can also experience recurrent yeast infections and prolonged wound healing. The picture here for you on my slides, just to help you kind of remember a lot of the risk factors associated with type 2 diabetes. Nutritionally, most patients are being encouraged to do carb counting. These days, 45 to 60 grams of carb per meal is the goal. 1 unit of carb is equal to 15 grams of carb. So just some things you want to keep in mind. You can refer to diabetes exchanges. Some of them, diabetics, that's an old way to kind of manage their diets, or My Plate, just using some visuals on how much of their plate should be what kinds of food. But generally, the protein that these patients will take in are the same as for the general population. The fat is really not any difference there either, unless the patient also has increased cholesterol or lipid levels, and they might want to decrease that, or just for overall health. For carbohydrates, it is more recommended that they use complex carbohydrates, whole grains, fruits, vegetables, and low-fat dairies. Alcohol. What does alcohols do to diabetics? And I know it seems strange because we think of alcohol as being full of sugar, but alcohol can, because it is full of sugar, it uses up all the insulin available, and then the patient can have a hypoglycemic reaction. So only moderate alcohol consumption with meals can be tolerated by these patients. 1 drink for a woman, 2 drinks for men. We do recommend they avoid the high sweet mixed drinks, that they adequately hydrate with water while consuming alcohol, and do self-monitoring of blood glucose levels while consuming alcohol. Exercise. What does exercise do with these patients? It is recommended they do 30 minutes, 5 days a week of moderate intensity, walking or swimming or exercise. 1 hour after a meal, or have a 10 to 15 gram carbohydrate snack before exercising. If these patients' blood glucose levels are less than 100, then they should eat 15 grams of carbs, wait 15 to 30 minutes, recheck, and not exercise until the blood sugar is back up above 100. Also, if their blood glucose level is greater than 250, they should drink fluids and wait until there are no ketones in their urine before they exercise, because they are at increased risk for dehydration. When patients exercise, it actually decreases the need for insulin because muscles use glucose directly, and it decreases insulin resistance in type 2s. You would think you would increase their need for insulin, but it might actually decrease their need for insulin. Oral hypoglycemics. I have some of those listed at the end of this presentation. So skip on over to the Somogyi effect and the Dawn effect. You guys remember those kinds of things, and you might be asked about those on the HESI or the NCLEX. Remember that the Somogyi, like a sumo wrestler or whatever, but these individuals are not getting enough insulin, and so they take their insulin at night, their basal insulin, and it's not enough. So while they're sleeping, their blood sugar drops, and then all those counter-regulatory hormones come into play and break all this stuff down and try to get the glucose back up. So they wake up with this high glucose, and they actually need more glucose. The Dawn effect is kind of the opposite. These patients are growing. Oh, wait a minute. I think I may have said that wrong. But let me go on here and I'll back up if I did. The Dawn effect, let me read this one. Okay, I think I got it right. Anyway, the Dawn effect is usually with a type 1 insulin-dependent diabetic, and it's the younger patients that have been diagnosed with that. And when they go to sleep at night, their blood sugar drops because they're growing and they need a lot more energy. And then again, same kind of thing happens, counter-regulatory hormones react, get the blood glucose up. And these patients are also high in the morning, but they actually need, I want to say, less insulin. And the emojis actually need more. Gosh, let me get back to you guys on those. I might have had them mixed up. I'm trying to get out all these videos for you in a good amount of time so you can listen to most of it, give you time to prepare before your test. And I'm hurrying kind of through, and I didn't get to review some points, so please excuse me. And again, look it up. All right, getting back to diabetes. And I will tell you this, there is no questions on the Dawn or Somoji effect on your Unit 2 exam. But again, you might be asked about that on HESI or NCLEX. And I do tend to get those things mixed up. Now, let me just give me a moment just to think through this one more time. All right, so I think the Somoji, they need their insulin dose decreased. They have too much and it's causing hypoglycemia through the night. And then again, processes occur to get the glucose up. So they need less. But the Dawn effect with the people, the patients, the kids that are growing, they actually need more insulin. One of the questions I have seen as far as Somoji and Dawn go is the fact that when patients describe these kinds of symptoms to you, the best answer is to have the patient check their blood glucose, even if it's at 2 in the morning or whatever, whenever this is happening, or when they notice, if they notice that they become hypoglycemic during the night, the best answer is to be checking the blood glucose level so you can actually figure out what's going on. And as a matter of fact, a lot of times the answer is to check the blood glucose level, not to jump into action right away, but to do a little assessment. You have a minute or two to do a blood sugar in which you can then better determine what is actually going on with the patient. So that's a concept that can be used over in answering a lot of different questions. Okay, diabetes, especially insulin dependence, type 1s. What do diabetics die of? And I always ask that, and I get a lot of different answers. Their kidneys, a wound, this, that. And basically, they die of vascular complications. And when you have diabetes and you have these high glucose levels in your blood over months and years of time, it actually changes the lining of your vessels and it makes them thicker, which is why a lot of these patients deal also with cardiac diseases or stroke or something like that. But because it thickens and decreases the diameter of their arteries, they deal with what's called macroangiopathies and microangiopathies. So these patients, the macroangiopathies are when their larger arteries are affected and they are at more risk for a CVA, for CAD, for an MI, and for peripheral vascular disease. They also deal with what's called microangiopathies, which are the blood vessels that are affected that go to the eye, the kidneys, and the nerves, like at the very end of your feet. As we get distal or in the kidneys or in the eyes, they have very little tiny arteries. And when those thicken, obviously it can cause blindness, kidney failure, or peripheral neuropathy and nerve death. So a lot of times, chronically speaking, these patients, you just need to know how to deal with anyone, be aware of these complications that they might have. And when patients have retinopathy, or a decreased amount of blood flow to their retina, and it causes blindness. You need to be aware of that, especially with the elderly. You always want to make sure that these patients can see exactly what kind of insulin they are giving themselves and assess their ability to be able to check their blood glucose and read labels and that kind of stuff. Nephropathy. 20 to 40% of diabetic patients will develop damage to their kidneys. We always want to monitor and follow progression with creatinine levels and protein in their urine. They have found that ACE and ARBs medications delay the progression and give some degree of blood pressure control. So those are used frequently with these patients. Peripheral neuropathy. If they're dealing with that, 60 to 70% of diabetics can experience this, and it's a pain, a burning, cramping, crushing, tearing, or what they call paresthesias type of pain, very hypersensitive in their feet. If you've ever had your arm or something fall asleep, it's kind of like that feeling, but it won't go away. If you can imagine that never going away, and it's a kind of type of pain. So again, they do use a lot of different types of medication to help with the nerve type of pain, being gabapentin, pregabalin, and duloxetine, Neurontin, Lyrica, and Cymbala, respectively. Also, these patients are at risk for ulcers on their feet, and they wouldn't be able to feel a wound or an ulcer. So we have to teach the patients to actually visually, with a mirror or with a caregiver, to look at their foot top and the bottom of their foot and frequently. And I'm going to refer you further for what kind of shoes these patients should wear, and all of those kind of things. So these are all what we call more chronic complications of diabetes, are your macro and micro angiopathies. And the micro ones, specifically retinopathy, nephropathy, and peripheral neuropathy. By the way, be real careful in answering questions that are talking about nephropathy or neuropathy. I even myself have gotten that mixed up. Looking at them quickly, they can look alike. There are also some acute complications of diabetes. Acute complications are hypoglycemia and very high hyperglycemias. You must know how to manage hypoglycemia and the rule of 15. Remember, this is when the blood glucose is less than 70. Early symptoms include cool, clammy skin, cold and clammy, need some candy, change in level of consciousness, headache, shaking, tremors, irritability, nervousness, anxiousness, hungry, and the later symptoms will start to involve their vital signs with hypotension, tachycardia, and even seizures. This next slide is just a visual and to help you remember, again, some of those symptoms of hypoglycemia. And then we have a slide that goes over the hypoglycemic protocol, or the rule of 15, with you. Remember, if we experience these symptoms, we will check their blood sugar and then give 15 grams of carbohydrate. Wait 15 minutes and recheck the blood glucose again. If it is still not above 70, we're going to repeat the 15 grams of carbs and repeat checking the blood glucose again. Once it is stable, or 1 hour away from that time of when it is stable and it is 1 hour or more away from a regular meal time, we do provide a carbohydrate and protein snack, such as crackers, peanut butter, milk, something like that. But remember, our 15 grams of carbohydrate is more of your 4 ounces of juice. Remember, orange juice is what's usually used, but for renal patients, you must use apple juice. If the patient is unconscious, once again, you would have to go to your IV 50% dextrose or IM glucagon. Always put patients on their left side for nausea, vomiting. So just make sure you're familiar with hypoglycemia, the symptoms, the level, and the treatment. All right, this next slide is kind of, I usually draw this on the board, but this is kind of representation of what is known as DKA or diabetic ketoacidosis. So it's just a picture kind of showing you what actually happens with that condition. This big brown thing is the liver. Okay, so usually if we have no insulin, DKA is usually experienced with patients who have type 1 diabetes. It's usually a more rapid onset than other acute reactions. And again, it's because they don't have enough insulin, and they don't have enough insulin to get sugar or glucose into the cell. So our body reacts to that as an emergency, and it calls really upon the liver. The liver can either make glucose or from scratch, if you will, or it can break down stores of glucose that it has. So if it breaks down the stores of glucose, it's called glycogenolysis there, and it breaks it to glycogen and glucose. But if it makes it from scratch, it has to have breakdown of both fat cells and muscle cells. That would be proteolysis and lipolysis. And this breakdown in fat cells that the liver might use to make glucose produces a waste product among many of ketones. And this is a very acidic chemical. So what I guess what I'm trying to say is your body kind of senses this whole, I can't get any glucose into my cell, almost like a starvation response. And it will start to make glucose. Unfortunately, for a patient with diabetes, this will not help. It will only make their glucose levels higher and higher and higher, and they can't get it into the cell if they don't have insulin, but your body doesn't know what else to do, so it tries to make more glucose, hoping some will get in the cell, but it's not going to work, and I hope that all makes sense to you. All right. Symptoms of DKA are hyperglycemia and acidosis. Hyperglycemia is blood sugar is greater than 300. They will have polyuria, polydipsia. They do mostly because of that polyuria and the very high glucose levels in the blood, they will present with dehydration. And you can go back to the symptoms that you know about dehydration because they will have those symptoms. Also, metabolic acidosis, a low pH and a low blood and a low bicarb. These patients will have that small breathing or try to breathe faster to compensate and blow off some of that acid that the kidney is not doing here. Or your kidney actually gets overwhelmed because of all these acetic ketones in the bloodstream. Other symptoms of metabolic acidosis: weight loss, abdominal pain, nausea, vomiting, acetone or fruity breath, and hyperkalemia. So usually potassium levels do go up with acidotic conditions. However, the exception is diabetic ketoacidosis because of that osmotic diuresis and polyuria and large amounts of urine output that these patients are putting out. These patients can actually have low potassium versus high potassium that most patients with metabolic acidosis have. Hopefully that made sense. This next thing is just another slide to help you remember some of the symptoms of hyperglycemia and its symptoms that, spell the word flushed. So I'll let you look at that on your own. HHS, or hyperglycemic, hyperosmotic, non-keto syndrome, HHS or HHNS, is something that usually type 2 diabetics will experience. These blood sugars go greater than 600. Again, hyperosmolarity, the blood is very thick. It has a lot of sugar and glucose in it. These patients do also present with symptoms of very severe dehydration. However, since these patients have some insulin, this process over here, the gluconeogenesis, doesn't occur. The liver only breaks down its stores. It does not try to make new glucose from scratch. So because of that, they don't get the ketones and the acidosis, but we do have that really high blood sugars and dehydration. And because of that, they urinate quite a lot. So they are also at risk for low potassium levels. Okay, treatment of DKA and HHS, either one. At first, you want to make sure they have a patent airway, that they are breathing, and that they have oxygen administered as necessary. You do want to have IV access for these patients, 2 large bore IVs if possible, and apply cardiac monitors to these patients. The first things that we really want to do medically is to begin fluid resuscitation for that dehydration that they're experiencing, or it looks like they're experiencing, because of those really high glucose levels in their blood. So we do usually use 0.9 normal saline until their output is 30 to 60 an hour and their blood pressure is stabilized. 0.545 or half saline can also be used with HHS. The next thing that we want to do is to begin a continuous regular insulin drip. When patients are on these drips, I have seen them out on Med-Surg, but I don't know how you can manage a patient with insulin drips out there, because you have to check their blood sugar every hour and titrate the drip based on your blood sugar result. Before you start an insulin drip, make sure to check the patient's potassium level first. They may be low, and if you start an insulin drip, the potassium level can go even lower. So they may need potassium, what we call K-riders, potassium IV piggybacks, along with the regular insulin drip. Sodium bicarb can be used if acidosis is severe, but usually if you can begin the fluid resuscitation and an insulin drip and get the blood sugars down, the acidosis will correct itself. We can add, and we should add, dextrose to the IV once their blood glucose level hits 250. So once they get down to 250, we're going to add a D5.5, a D5 normal saline. We're going to add a dextrose solution to their IV so that they don't continue to bottom out. Okay. We kind of went over a lot of these insulins in simulation, but you need to know all the rapid acting insulins when there is onset, peak, and duration, Lispro, Aspart, and whatever this other one is, glulisine. Short-acting insulin are your regular insulins, Novolin or Humulin, or regular. Insulins, again, you need to know their onset, peak, and durations. Intermediate acting insulins are all your NPHs or your Ns, or your mixed insulins as well. And again, you need to know your onset, peak, and durations. Long-acting insulins, Lantus, Levemir, remember those do not peak, onset in an hour and last over 24. There are such things as combination or mixed insulins. This is some examples on this slide, and these are also classified as intermediate insulins. Here is a little mnemonic or a poem that can help you remember the onset, peak, and duration. For instance, rapid acting insulins. 15 minutes feels like an hour during 3 rapid responses. So rapid acting insulins, 15-minute onset, peak 1 hour, duration 3 hours. So this is just a little saying, if you can remember it, that is, that you can use to help yourself remember those insulins. This is another drawing someone gave me at one time. You can see it spells the word insulin there in the middle, and it has all these different types of insulins. And if you put these in the right order, you'll get your rapid, short, intermediates, and longs. Subcutaneous infusions, insulin pumps. They can use any of the regular or rapid insulins. Oral hypoglycemics. There are a lot of these, and these are like the main classifications of the oral hypoglycemics. I would know, if I were you, everything I could about biquinides, example glucophage or metformin. These oral hypoglycemics work through the liver, and they help to decrease the amount of glucose that the liver might make. Sulfonylureas, some examples are glimepiride, glipizide, glyburide. This group of oral hypoglycemics works through the pancreas and actually stimulates insulin production. So out of these two groups, which one do you think would be most at risk to cause hypoglycemia? And it is the sulfonylureas, the ones that actually increase stimulation of insulin. All right, I think that's all. So again, this is just a short review, an overview of all of glucose regulation. Don't have 3.5 hours or whatever to give an entire lecture. As far as your exam too that's coming up, you need to know macro, micro angiopathies, those complications of diabetes. You would need to know if a patient comes in for treatment, what if he were given a set of different types of lab values or vital signs, what might indicate a need for change. Remember, if a patient is at 6.5 A1C, that may not indicate a patient needs any change in treatment, because it would be expected that they would be around that number. However, if a patient with diabetes comes in and they have high blood pressure, and you already know they're at risk for complications of macro angiopathies, they might need to be started on an antihypertensive, and that would change their therapy, right? I mean, you just have to think through the question, and the answers are not always what you think they're going to be, So you have to think through using the knowledge that you have and what's expected and what isn't from these patients to know if something is needed or not. That's the best I can give you without reading a question to you. The oral glucose tolerance test, we did talk about that. There is questions on that. Hypoglycemic protocol, there is definitely questions on that on this next exam. And remember, whenever something is expected in an acute way, you want to check the blood sugar first. All right, I think that's it for this one. Hopefully that helps. That gives you kind of stimulates your memory on all of this kind of stuff, helps you know what you do know and what you need to go back and review and that kind of thing. So hopefully this is helpful to you. And I will be doing, I think, one more of these voiceovers is GI, and I will try to get that done for you guys tomorrow, if not by Wednesday. Okay, thank you. And let me know, as usual, if you have any questions.